Good afternoon, everyone. I see it's just a little bit past 1:30, so we're going to go ahead and get started. Thank you all for taking the time to join the first event in the Medical Research and COVID-19 series. Before we begin, I wanted to go over just a few housekeeping items. Because we are using Zoom's webinar format, all audience members will be muted throughout the discussion, but there will be time for questions at the end. So to ask a question, you can just use the Q&A function to type your question in the box there. When you submit a question, please be sure to include your name and the full name of the organization or your office. And we would recommend switching the view to the hide all non-video participants view. I would also like to note that this briefing is not open to members of the press, so if you've joined us inadvertently, we appreciate your interest, but would kindly ask that you disconnect at this time, and we'd be happy to follow up with you separately. I'm Tanaz Rasuli with the Association of American Medical Colleges and Executive Director of the Ad Hoc Group for Medical Research. The Ad Hoc Group is a coalition of more than 300 organizations representing patients, scientists, clinicians, educators, institutions, and industry that support enhancing the federal investment in the research conducted and supported by the National Institutes of Health, or NIH. We are pleased to be co-hosting this event today with the Coalition for Health Funding, the oldest and largest nonprofit alliance working to preserve and strengthen public health investment. CHF's 92 member organizations together represent more than 100 million patients, consumers, health providers, professionals, and researchers. As you know, NIH-supported medical research across the country is a key tool in battling COVID-19 and its wide-ranging effects. Our organizations partnered on this series to give both advocates and congressional staff an opportunity to hear from the directors of NIH's individual institutes and centers about how research that they've supported up to this point and ongoing work can help inform our response to the virus and other public health threats, as well as the impact that the pandemic is having on existing research across the agency's broad portfolio. We have two moderators for today's briefing. Wendy Noss, who is the Executive Director of the Consortium of Social Science Associations and is a member of the Ad Hoc Group Steering Committee, will facilitate the Q&A portion of the discussion. And to introduce our speaker for today's briefing, I will turn things over to Ben Korb, who is Director of Public Affairs at the American Association for Biochemistry and Molecular Biology, and is President-elect of the Coalition for Health Funding. Ben?
Thank you, Tanaz. The CHF and Ad Hoc Group are pleased to welcome Dr. Eliseo Pérez-Stable, Director of the National Institute on Minority Health and Health Disparities, to our first event in this series. Dr. Pérez-Stable oversees the Institute's $281 million budget to conduct and support research, training, research capacity and infrastructure development, public education, and information dissemination programs to improve minority health and reduce health disparities. NIMHD is the lead organization at the NIH for planning, reviewing, coordinating, and evaluating minority health and health disparities research activities conducted by the NIH Institutes and Centers. Dr. Pérez-Stable's expertise spans a broad range of health disparity disciplines. His research interests have centered on improving the health of racial and ethnic minorities in underserved populations, advancing patient-centered care, improving cross-cultural communication skills among healthcare professionals, and promoting diversity in the biomedical research workforce. Dr. Pérez-Stable practiced general internal medicine for 37 years at the University of California, San Francisco, before moving to the NIH in September of 2015. He was a professor of medicine at UCSF and chief of the Division of General Internal Medicine for 17 years. His research interests include improving the health of racial and ethnic minorities in underserved populations, advancing patient-centered care, improving cross-cultural communication skills in clinicians, and promoting diversity in the biomedical research workforce. For more than 30 years, Dr. Pérez-Stable has led research on Latino smoking cessation and tobacco control policy in the US and Latin America, addressing clinical and prevention issues in cancer screening, and mentoring over 70 minority investigators. He has published over 250 peer-reviewed articles and was elected to the National Academy of Medicine in 2001. With that, I will turn it over to you, Dr. Pérez-Stable, to give an overview of NIMHD's current activities. When you are finished with your presentation, Wendy will open it up to your audience, and I thank you in advance for this really exciting event.
Unmute. First step in this effort. So thank you very much for having me present to you in this first of a series of special activities on COVID and research. It is a really incredible year. It's a special year for NIMHD in many ways. It is our 10th anniversary as an institute, our 20th anniversary when we started as a center, and then also it was 30 years ago that the Office of Minority Health Research was started at NIH by then Secretary of Health and Human Services, Lou Sullivan. I'm also pleased to say that it's been slightly over 5 years since I became director at NIMHD. And over this time, there have been a number of new directors, so I am far from being new at this position. And yet we are living through an unbelievable pandemic, a global crisis that is unprecedented of any of our lifetimes. And I predict will probably be unprecedented at least for the next generation. And I also think that this is a change in the way we do things, that this is not over in 3 months, it's not over in 6 months, and we have to see how we adapt and manage this new reality of facing a world where we have respiratory viruses that lead to these kinds of adverse outcomes, at least in the foreseeable future. In thinking about the NIMHD agenda as an institute within NIH, it is one of several institutes that has a NIH-wide portfolio. We are not limited to one age group. We're not limited to one disease entity or one group of diseases based on physiological systems, but we really go from pregnancy to death. We have grants that focus on end of life as well as infant mortality or maternal morbidity. We are interested in all of the populations with health disparities, which include the racial ethnic groups identified in the US Census, all of them. It includes rural residents, especially those who are underserved. It includes poor people of any color. These are 3 mandates by legislation. And as of 4 years ago, we declared sexual gender minorities also as a population with health disparities. We embrace the notion that all of these populations are unified in a mechanism of being suffering from being subjected to discrimination at some point in their life course, and that this has led to social disadvantage. In science, we are increasingly understanding these mechanisms. This is the model of chronic stress, cumulative chronic stress, or adverse childhood events. An event that happens early in life can affect your health as an adult or in your 40s. And the same kind of cumulative micro stressors that happen from other aspects, being poor, not having adequate access to healthy foods, being homeless at some point in your life, losing a parent, losing a sibling, other kinds of traumatic events. These cumulative stressors of being discriminated against and living with adverse events add up. And this is one of the factors that helps us explain and understand health disparities. Now, in thinking of minority health and health disparities, they're important to differentiate. First, in minority health, we're specifically interested in the race ethnic minorities in the US, whether the outcomes are worse or not. And interestingly, some of the minority groups have better outcomes for many of the leading causes of death and disability. This is science research that we want to know, well, what is it about those groups that lead to better outcomes? And so this is a part of our portfolio that exists as well. And in health disparities, when one of the populations with health disparities has a worse outcome, more cancer, more heart disease, more strokes, more hypertension, more COVID, compared to a reference group, that's what we're calling a health disparity. We know very little about some groups. We know a lot more about others, but this is advancing the science. So you can see that this is a mission that goes to every institute at NIH. So I, as a director, interact or deal with every institute. We drafted and vetted a 5-year strategic plan that is in its final phase of clearance with the department, that included input from an NIH-wide committee multiple times, and then multiple interactions with institute directors to get their input, to get their sign-off on what we were drafting, not only as strategies in research, but also getting buy-in on what I called bold initiatives, goals, reach goals that related to one or another institute differently, and many of them, of course, were our own. Our research framework includes issues around behavior, biology, the environment, both the physical environment and the cultural environment, as well as the healthcare system. And we focus on individuals and interpersonal and community and society. So health policy research or health services research are part of our agenda, as well as community engaged or community-based participatory research, how families function and interact, how communities function in terms of defined communities, and then individual factors. And this is, I think, a framework that can apply to any of the NIH institutes in thinking about these issues. We do not fund much in basic science as part of our focus. Over 50% of NIH's budget goes to basic science. And so there's a lot of terrific science going on in the rest of the institute. Some of our programs do have basic science, but most of our research starts with mechanistic research and then goes on to clinical, community, and societal. Let me pivot to talk about our disparities in COVID, because this year has really spotlighted the importance of health disparities. So the pandemic, as we well know, we've been in sort of shelter in place, mostly working from home for many of us, if not most of us, since March. And early on, so by the end of March, beginning of April, we began to see an emerging pattern of initially increased mortality for African Americans, more severe disease, higher death rates that became clear in reports from Chicago, New York, New Orleans, and selected other places where the hotspots were initially in that spring. As we began to collect better data and more data, and where we are today, over 50% of all cases of COVID in the US right now are either in African Americans or Latinos. Over 50%. And knowing that about 35 or so % of cases do not have race, ethnicity ascertained in their reporting, even today, even after the department has made that a requirement. It's up to the local health departments to do it. Some states are better than others, and I think we have to keep working on getting better reporting. In a minority health perspective, American Indians, particularly in the Navajo Nation, White Apache area in the Southwest, have also suffered disproportionately. Pacific Islanders also appear to have had disproportionate burden in reports from California, as well as from the state of Hawaii. And this is all related to primarily the increased risk of infection. So its infection rates are due to what kind of work minorities are disproportionately tasked to do. They're more public facing jobs. They're in the grocery stores, they're in the transportation sector, they're in construction. They can't work from home. They do not have that privilege, and a higher proportion than others. All groups have proportions that are affected by this, but this is the primary reason that we see higher infection rates, and this is the primary reason why we have seen people, Latino Hispanics, to become the highest proportion of COVID cases in the country are in that population. 30% of cases, 18% of the population. And among children, even though it's much less common, they also have a disproportionate burden of cases and deaths. The second reason we see higher transmission is the way most of the minorities live. They live in more crowded housing, 3 generations in a single household, or 2 families in a single household. So exposure by one person who goes outside to work to their home is not one other person or 2 or 3, it may be 10. and may include a frail older adult or someone with a chronic disease. And there you see the chain of consequences. And also these minority communities are concentrated in urban centers that are more crowded. There are buildings with apartments or houses that are next to each other, as opposed to more suburban, more space between houses. So these are the primary reasons. Once infected, we do know that there are comorbid factors that increase risk of severity and death. The primary one is diabetes. The secondary one, almost as important, is heart disease of any kind, even hypertension. And then chronic lung disease is the third. And then a host of other conditions that can affect your immunity, including pregnancy, may also lead to increased severity. We've gotten better at treating COVID, so the death rates have decreased, especially as we protect the older adult population, and more younger adults have unfortunately been infected. We have not seen the mortality rate that was being seen in late March and the month of April. Now, NIH's response has been incredible. Dr. Collins has gotten us working harder than I have ever worked since I was probably an assistant professor writing my first grant, working from home, meetings back to back. And there are three major programs that I just briefly tell you about that NIMHD is co-leading. The first was in response to the ideas of science response, brainstorming ideas, the social, behavioral, and economic implications or consequences of the pandemic and its mitigation. We formed a coalition with the National Institute on Aging, National Institute on Mental Health, and the Office of Behavioral and Social Science Research to fund a series of supplemental awards to existing grants in these topics. This continues to this day. We plan to continue funding now new grants in fiscal year 21. We approved 52 of these supplements. The awards haven't quite yet been made. And in addition to the supplemental awards made by individual institutes, including our own, to applications that we solicited from researchers. The second program is the Rapid Acceleration Diagnostics for Underserved Populations. These were supplemental appropriations in April to NIH. Much of it was focused on development of new, innovative, and point-of-care access technology that went to the National Institute of Biomedical Imaging and Biomedical Engineering, as well as the National Cancer Institute. That has not completed, but is close to completing their phase of getting these technologies that can be tested and commercialized. But Dr. Collins decided to allocate a significant amount of resources, $500 million over the next 4 years to the program for underserved populations. He asked NIMHD, National Institute on Aging, and then the Office of the Director to co-lead this. We are about to announce those awards next week. And there will be 29 awards to existing, again, done through supplement to existing networks and centers to reach out to underserved and vulnerable populations to promote testing by whatever method they have proposed to do and available, and to retain the data identifiable with the idea of tracking the individuals to try and develop strategies for decreasing the disparities that we observe in these populations, addressing the issue of contact tracing and self-isolation as needed, and then setting up for what we hope will be deployment of effective vaccine and therapeutics in the following year. So we are ready to pivot to that if and when that time comes. And then the final program is the Community Engaged Alliance Against COVID-19 Disparities. This was came out of an effort of addressing to make sure that the current vaccine trials and then therapeutic trials have inclusion, have diverse participants in their samples. The early experience with the first trial, the Moderna trial, as has been written about, was not as we would have liked to have been. They understood that, they realized that, and they have improved, and they have modified their methods in order to increase the participation of African Americans especially, but also the Latino community in their studies. And we have, with, again, resources mostly allocated from Dr. Collins and other institutes, but also NIMHD, funded 11 state consortiums, mostly in the South, East, but also Texas and California and Michigan, to focus on what we would say addressing the misinformation about COVID, which has unfortunately disseminated widely, to build on trust, to create trust in science as a mechanism to promote participation in our studies, and then to enhance the inclusion of African Americans, Latinos, American Indians in these clinical studies that have been rolled out. Most of them in collaboration with NIH, although obviously the companies are running the studies for the most part. Finally, I will just make a comment about effect on science and review. Our scientists are stressed just like we are. Those who have projects that are in the virtual space and digital are doing okay. They're continuing to do what they always do. But many who were in the community were paused or hesitant. Many are now realizing this is a marathon. They are reactivating with care, with appropriate measures such as masks and physical distancing to continue their research. There is concern, and NIH has been as flexible as possible in submission dates and no-cost extensions. I believe on the review side, there has been, it's been incredible. They have pivoted to entirely virtual review, even as early as March, where that started. They had already had experience doing some of that in the past. And I think, if anything, we'll learn that more of this can be done virtually in the future, even if not necessarily 100%. And I have not heard any concerns about how review has done, other than the normal things, oh, you lose connectivity, or it's not the same as being in the same room with someone and talking to them. But given those limitations, the review process, I think, has gone fairly well for NIH as a whole. And certainly for NIMHD, there haven't been any special problems. So I'll pause there and happy to entertain questions or comments.
Thank you so much, Dr. Pérez-Stable. A lot of food for thought there. And, you know, one reaction that I have immediately representing my organization and the social and behavioral science community is I'm so happy that you got to go first in this series, because I think if nothing else, your institute understands the issue of intersectionality, especially when it comes to COVID and disease. And you gave us some sobering statistics about sort of the minority health impact related to workplace and housing. So I'm wondering, could you say a little bit more of either what the Institute is doing or maybe planning to do down the road on the issue of misinformation, community engagement? I know that you have a new community engagement alliance that's been announced to really get to the point of intersectionality, these different impacts and factors that are going into COVID response.
Yes, happy to. So just before this call, I actually left early a meeting of the principal investigators of this, what we call the SEAL initiative with a C. So it's Community Engagement Alliance Against COVID. Because we're partnered with an institute that's 10 times our size, the National Heart, Lung, Blood Institute, we were able to stand this up. Otherwise, we wouldn't have the staffing or the knowledge to do this, especially through this mechanism. But NIMHD provided 2 decades of history of working with these investigators. Most of the places that were funded are led by centers that, or individual investigators that we have funded. This is a benefit of having been committed to community engaged research, even if we had to create a set aside for it, even if we knew that they weren't necessarily going to be accepted in the mainstream of NIH. this was a credit to NIMHD long before I got here under Dr. Rothman, and we are committed to continuing this. And this was an opportunity to leverage that and pivot them into action. I'm very pleased, at least with the initial response. This is set up for at least a year. It's not like a regular R01 mechanism. But I'm fully expecting this to not end in a year, because pandemic is not going to end in a year. And we're very focused on participating in trials now, but we'll need to address vaccine hesitancy. It's very sobering when we were in a community forum of African Americans organized by the National Urban League, that 90% of people who were participating in that forum said they were hesitant to accept taking the vaccine in the first year. And that's a concern. That's a big concern. They had this mistrust and has been generated and reinforced by misinformation. And we can't necessarily change that overnight. We just have to work at it with trusted local leaders and address this. Whether we also do more classic research in the social behavioral population science perspective will depend on applications. We are talking about developing something on vaccine hesitancy within an NIMHD. And so because this is going to be an ongoing issue, I think you will see other kinds of research grants coming out of this, as well as the supplements we funded. The supplements we did, the first initiative I told you about, are research projects on interventions, as well as additions to existing cohorts or surveys or studies of different populations.
So I welcome questions from others participating using the Q&A function. I will continue with my line of questioning until I see something come through. So to one of the points you just raised, and what you started off by saying is we're in a new reality. It isn't as though COVID is going to end and things are going to go back to the way that they were. Broadly, but certainly within research. I'm wondering, and you mentioned that you have a new strategic plan that no doubt had a lot of work done long before COVID was a household name. And so has the Institute been able to spend any time thinking about the future investments sort of beyond the immediacy of COVID? And are there any lessons learned from this pandemic that, not if, but when the next emergency arises, at least from where your institute perspective is, that we could change and make things better the next time around?
Yes, so building on what we put in the strategic plan, what we published a year and a half ago in the American Journal of Public Health for research strategies, and also building on our research framework, that gives us a guide, a map of how to respond and pivot to any crisis that presents itself. So I don't think, COVID obviously has a lot of specifics that we would need to address and think about, but the framework is there. And the response, thinking about why the disparities, how do we mitigate these disparities, how do we address these, I think we have the tools to be able to address that. That's why I feel comfortable in the way we've responded to this. Initially, it was like, oh, it's an infectious disease. What does NIMHD have to do with it? And within a few days, it was like, oh yeah, we got all this stuff that can be done, and now it's even just keeps growing, and there's more coming. So what would we do? I mean, one is to continue to build these networks and infrastructure. For example, we fund a group of tribal epidemiology centers across the country. This has been in partnership with the Indian Health Service. It's actually their CDC program. We want to take ownership of a certain part of it, build capacity in those 9 sites through both the data science tools as well as mentoring tools to develop research capacity in the Native community. That's one. Another idea that I would like to see us develop is some sort of research network. Most institutes have some sort of clinical research network that they do, because they do clinical trials in diabetes or stroke, or in the case of heart disease or cancer, and they invest significant amounts of resources in that. We don't necessarily need a clinical trial network, but it would be good to have a network of on the ground practitioners who take care of patients who are from populations with health disparities. And so I'm thinking about that kind of a practice-based research network that focuses on minority and other health disparity populations as another idea. Continuing to fortify and build on this community engagement model. It takes time to build those relationships. It takes time to get trust. And the results are gradual, sort of a delayed timeline. But the benefits, I think, are clear, especially as our country becomes more diverse and more complicated, frankly, in many ways. And finally, I would just comment that I think we have the tools today to be able to show how we can have a disadvantaged, poor community do better. It will take an effort, of course, with other resources, to do demonstrations or research projects on this for building healthy communities that involve not just the health sector and not just social services and social scientists, but also housing and transportation, criminal justice system, the other sectors in society that impact our health that we have not usually worked with. And I think the healing communities that were funded through the HEAL initiative have been an example of that. And I think that there is potential to develop something in those orders. So I realize we're past 2, but
well, I'm realizing that we probably should have scheduled 1 hour for this briefing, but since we promised that we would only take up 30 minutes of your time, I will take the opportunity to thank you both for joining us, but also to you and your colleagues for the work that you all are doing every day. We hope this is obviously the first event in this series, but we hope it's also the first in a series of briefings with you. So hopefully you will accept our future invitations as well to come back and update us on the progress along all the lines that you discussed today. I'll also thank Ben and Wendy for co-hosting the briefing today, and to all of you who were able to participate. Hope you are all able to join us 1 week from today for the next event in this series, which will feature Dr. Joshua Gordon, the director of the National Institute of Mental Health. Thank you again, and stay safe, everyone.
Thank you, Tanaz. Thank you, Wendy. Thank you, Ben. And stay safe, everyone. Thank you very much.